Hello everybody. Today's topic of discussion is intracranial bleed. So we have this 70-year-old male patient known case of hypertension, diabetes mellitus, CKD on maintenance hemodialysis. He was transferred to our hospital from the BRC hospital. He suddenly became unresponsive. CT brain done which showed IC bleed with the intracranial extension, and then he referred here for the further management. On arrival in ER, his pulse was 80, blood pressure was 140/90, respiratory rate was 16, saturation was 100%, CVS S1 S2 present, RS air entry was equal on the both sides, per abdomen was soft. On CNS examination, we found he was E1, VT, M2, and pupils were pinpoint bilaterally. So we did CT brain, which showed intraparenchymal hemorrhage with the mild perilegional edema in the right thalamus causing the mass effect, and intraventricular extension was mentioned. There was no midline shift. There was mild to moderate hydrocephalus with the intraventricular hemorrhage and periventricular oozing. So after that, he underwent dialysis for 4 hours. This was the ABG of the patient. This was the blood investigation. Patient was treated with Dexa, 8 mg BD, mannitol, Levipil, then his other antihypertensive medicine. Now we will see what is this intracerebral hemorrhage. Intracerebral hemorrhage refers to the bleeding within the brain tissue and may be divided into traumatic and non-traumatic categories. Non-traumatic ICH occurs in the setting of cerebrovascular disease and represents the second category of the stroke after ischemic stroke. Non-traumatic ICH occurs less frequently than intracranial vascular disease but carries the higher mortality and often requires management in the ICU. Most of these cases are caused by the spontaneous ICH, defined as bleeding within the brain parenchyma without an underlying cause. Half of primary ICH cases result from the long-standing hypertension. Owing to aggressive control of hypertension, the incidence of ICH has decreased since mid 1960s. Nonetheless, the ICH accounts for 4% to 11% of all stroke cases in the United States and 16% to 26% of all stroke related deaths. Now, regarding pathophysiology, many cases of primary ICH attributed to underlying hypertension and are believed to be caused by extravasation of arterial blood from the ruptured microaneurysm along the wall of small intracerebral arterioles. These microaneurysms are known as Charcot-Bouchard or miliary aneurysm that tend to form vessels at the usual site of ICH and develop at the site of vascular branching where mechanical stress is maximum. The aneurysm wall lacks the normal vascular histology and is composed mainly of the connective tissue layers, which represents the weak point in the arterial system. The formation of this aneurysm is favored by the process of lipohydinosis and fibrinoid necrosis, which weakens the wall of arterioles and are accelerated by the chronic hypertension. Although Charcot-Bouchard aneurysm also appear in the normotensive aging brain, their frequency is notably increased in the hypertensive patient. They are commonly observed along the lenticulostriatal arteries, thalamoperforator arteries, paramedian branches of the basilar artery. Although this distribution corresponds to the common site of ICH, it is impossible to prove that these aneurysms are always the cause of bleeding, and the concept of arterial microdissection has been raised as an alternative explanation. Elderly patients, particularly those with the history of cognitive impairment or dementia, can develop lobar ICH related to amyloid angiopathy, and this is the important underlying mechanism of ICH. About 5% to 10% cases of spontaneous ICH results from the amyloid angiopathy, making it second to hypertension as an etiology for ICH. Age-related deposition of beta amyloid among the small arterioles is thought to increase the vessel wall fragility through decreased elasticity and render the artery susceptible to spontaneous rupture. Other underlying causes include vasospasm, vasculitis, bleeding disorder, prior embolic infarction, ruptured Berry's aneurysm, or vascular malformation. Irrespective of underlying cause, continued extravasation of the blood results into the formation of hematoma with secondary accumulation of cerebral edema. The region may become large enough to cause midline shift of the cerebral structure, followed by the transtentorial herniation. Depending on the size and the location of ICH, intraventricular extension can occur leading to the development of acute obstructive hydrocephalus or later the development of chronic communicating hydrocephalus from impaired cerebrospinal fluid reabsorption. Some cases of thromboembolic stroke may be misclassified as ICH because blood may extravasate and accumulate into large hematomas in the area of the infarction. The secondary hemorrhage may be mislabeled if an early imaging study is not performed. Now, regarding clinical manifestations, for most cases, the onset of ICH is during the waking state when the patient is active. The onset is abrupt and the development of neurological deficit occur progressively over minutes to hours. The clinical presentation of ICH is monophasic with the symptoms rapidly progressing to the maximum. Subsequent clinical deterioration is usually because of the effect of cerebral edema and secondary bleeding, and subsequent deterioration may also, may also occur. It was recently suggested that thalamic hemorrhage may bleed further among patients whose hypertension is not adequately controlled. This contrasts with the fluctuating deficit or commonly seen in atherothrombotic infarct or with the appearance of maximal deficit at the onset of cardioembolic stroke. At presentation, 44% to 72% of patients with ICH are comatose. The average age of onset of ICH is 50 to 70% younger than that of the other type of the stroke. Patient may report lateralized headache, vomiting is common, and knuckle rigidity may also be present. Seizures are seen more commonly at the onset of ICH. It occurs in approximately 17% of patients than in intracranial vascular disorder and is more likely to occur if bleeding involves cerebral cortex. Now, regarding diagnosis of ICH can be made by the head CT, which provides accurate information about size and the site of hematoma, as well as the midline shift and development of the cerebral edema. Typically, hemorrhage is hyperdense on CT scan during acute phase, although severe anemia and ongoing hemorrhage may attenuate this finding. Acute ICH may be identified by MRI, but MRI is less readily available and requires a longer imaging time. In addition, the appearance of the blood on the MRI scan varies with the time because signal intensity is related to the state of degradation of the hemoglobin. For typical ICH, deoxyhemoglobin is found during the first 3 days after ICH and is not well visualized by the T1 weighted images, but appears as an area of reduced signal intensity on T2 weighted images. During day 3rd and 10th after ICH, methemoglobin appears as an increased signal intensity of T1 weighted images, but the intracellular portion has reduced signal intensity on T2 weighted images. During chronic phase, the ICH has broken down into hemosiderin, which is poorly visualized on T1, but appears as a reduced signal intensity on T2 weighted images. CT angiography and MR angiography or conventional angiography should also be considered for selected cases when underlying aneurysm and the arteriovenous malformation is suspected. This is particularly important or pertinent for younger patients and those with the bleeding in an atypical location, in whom larger percentage of cases of ICH are caused by underlying vascular lesion such as AV malformation or aneurysm. Lumbar puncture is contraindicated during acute ICH because of the risk of herniation from the muscle. Testing on admission for ICH should include coagulation profile, platelet count for all patients, as well as bleeding time when the patient is on aspirin. Now, regarding differential diagnosis, although the vasculopathy related to hypertension and amyloid angiopathy constitute the majority of ICH, the other etiologies should be considered. The ruptured AV malformation is an important cause of ICH, particularly for younger patients and those without the other risk factor. ICH may also occur uncommonly from ruptured cerebral aneurysm. Typically, the blood is also evident into the subarachnoid space. Secondary cerebral hemorrhage may occur after embolic infarction, as the large embolus fragments and ischemic distal vessel may rupture with the reperfusion. This is more common for patients with the large embolic infarct, among patients who are anticoagulated, and among patients with poorly controlled hypertension. ICH accounts for 0.5 to 1.5% of all bleeding events related to the use of oral anticoagulant. Oral anticoagulation increases the risk of ICH 8 to 11-fold compared with the unanticoagulated patient. Compared with patients with spontaneous ICH, there is trend towards large hematoma and higher mortality rate in patients on anticoagulants. Cerebellar hemorrhage is relatively common among anticoagulated patients, and mortality for these cases may be as high as 65%. Therefore, among anticoagulated patients, the onset of focal neurological sign, even if slowly progressive, necessitates CT scan to rule out ICH. The use of fibrinolytic therapy such as RTPA for coronary artery occlusion has also been associated with ICH, especially when adjunctive anticoagulation therapy is used. These cases have shown the predilection for subcortical white matter and lobar areas and generally have poor prognosis. ICH associated with the presence of primary or secondary brain tumor is infrequent and accounts for only 2% of all cases of ICH. High-grade malignancies such as glioblastoma multiforme are more likely to bleed. The presence of thin wall vessels in the area of the neovascularization is thought to be the underlying reason for this hemorrhage. Metastatic lesions with the tendency to bleed include the bronchogenic carcinoma, melanoma, renal cell carcinoma, and choriocarcinoma. ICH is frequent in hematological disorders such as leukemia, and it reflects the underlying thrombocytopenia and DIC. When DIC is caused by other organ failure, it also can lead to ICH. Now, regarding sympathomimetic drugs such as methamphetamine, pseudoephedrine, and phenylpropanolamine may cause ICH. These agents are suspected of inducing vasculopathy with vasospasm and sometimes vasculitis. Like cocaine, which blocks the dopamine and norepinephrine uptake, has been associated with ICH and appear to incite cerebral vasospasm rather than the vasculitis. The secondary hypertension related to the sympathomimetic stimulation may also cause ICH from any of these agents. This explains the lack of abnormal angiographic finding among some of these cases, although recently cerebral vasospasm was demonstrated with MRA after acute cocaine administration. Reversible cerebral vasoconstriction syndrome describes a temporary process of triggered multifocal vasospasm, and patient may present with the acute ICH. The secondary hypertension related to the sympathetic stimulation may also cause ICH from any of these agents. This may explain the lack of abnormal angiographic finding among some of these cases, although recently cerebral vasospasm was demonstrated with the MR angiography after cocaine administration. Reversible cerebral vasoconstriction syndrome describes the temporary process of triggered multifocal vasospasm, and patient may present with the acute ICH. The triggered event include exposure of the pro-serotonergic medications and marijuana, but no apparent source may be found. Acute elevation of the blood pressure in otherwise normotensive people, such as that which may follow migraine, is postulated to result at times in ICH. ICH secondary to the focal autonomic dysregulation after carotid reperfusion may also occur typically 3 to 5 days after revascularization in patients with suboptimal blood pressure regulation. Now, specific syndromes of IC bleed. Hypertension related ICH tend to occur in stereotype locations. In order of descending frequency, the locations are putamen, subcortical white matter, thalamus, pons, and cerebellum. So putamen has the highest frequency, that is 30% to 50%. Subcortical white matter 15%, thalamus 10%, pons also 10%, and cerebellum 10%. ICH in the putamen is caused by the bleeding from the lenticular striate vessels. Clinically, it is manifested by the development of flaccid hemiplegia, hemisensory disturbance of all primary modalities, homonymous hemianopia, paralysis of conjugate gaze to the side opposite to the lesion, and early alteration of the level of consciousness. Subcortical aphasia may occur when putamen hemorrhage involves the dominant hemisphere and hemineglect syndrome when it is on the non-dominant side. Thalamic ICH is characterized by the unilateral sensory motor deficit in which sensory findings are predominant. A variety of eye signs occur, including Paranoid syndrome, force disconjugate down gaze deviation, medially on the side opposite to the lesion, and then pseudo-obtusance paralysis and upgaze paralysis. Owing to the location, thalamic ICH may rupture into ventricular system. Pontine ICH has the highest mortality. Quadriplegia, brainstem dysfunction, small and unreactive pupil are seen at presentation, and many patients rapidly develop coma. Bleeding typically arises from the paramedian branch of the basilar artery and almost always extend into the fourth ventricle. The cases of unilateral pontine ICH have better outcome. Cerebellar ICH most commonly involves the dentate nucleus. Alteration of consciousness is unusual at onset, but progressive deterioration with drowsiness typically occurs. Most patients initially present with the following, that is gait and truncal or limb ataxia, lower motor neuron facial paresis, and ipsilateral gaze paresis. Other common presenting signs and symptoms are headache, nausea, vomiting, vertigo, nystagmus, and limb ataxia. Early surgical intervention is indicated for lesion larger than 3 cm or in smaller lesion with the clinical progression, because cerebellar hemorrhage causes the death in up to 60% of cases. Neurological deterioration due to hemorrhage causing obstructive hydrocephalus at the level of fourth ventricle is not uncommon. Surgical mortality is lower for patients who are still awake before operation, and therefore early intervention is indicated. Approximately 3% of cases of ICH are primarily intraventricular in location. These events have minimal focal sign, but there may be the loss of consciousness at onset. Hydrocephalus is the major complication. Now, regarding treatment, acute medical management of ICH is aimed at correction of any predisposing systemic factor to prevent further clinical deterioration. Following ICH, there is hematoma growth of 22% within the first 24 hours, and hypertension is the major management problem in these cases. In response to the acute elevation of ICP caused by hematoma, systemic blood pressure rises to maintain adequate cerebral perfusion pressure. This response is known as Cushing's reflex, serve to protect brain against the ischemia, but autoregulation of cerebral blood flow can be impaired after ICH or infarction. Among patients with underlying chronic hypertension, the result may be excessively high blood pressure, and the best management of this dilemma remains controversial. In chronic hypertension, the lower limit of cerebral autoregulation is shifted towards higher blood pressure, and acute lowering of the systolic blood pressure is known to result in unfavorable decreasing cerebral perfusion pressure. Sustained hypertension in the acute phase of ICH, however, can lead to a further bleeding or rapid accumulation of cerebral edema. The recommended goal of systolic blood pressure in acute phase of ICH is between 140 to 160. The blood pressure should be lowered gently, acutely, and the beta blockers are agent of choice. Alternatively, calcium channel blockers such as IV nicardipine may be useful because it does not elevate ICP like some vasodilators. When the hematoma and associated cerebral edema raises the ICP, clinical deterioration typically occurs. Acute hyperventilation effectively lowers ICP, but only for the matter of hours. Hyperosmolar agents such as mannitol and the hypertonic saline can provide more sustained reduction of the ICP. Their utility remains unclear, and the osmotic diuresis induced by this agent can lead to dehydration, electrolyte imbalance, and pulmonary edema if the patient is not carefully managed. Treatment of ICH with the steroid can be detrimental to overall outcome, and these are not routinely administered. The value of ICP monitoring in this situation remains controversial. An elevation of ICP owing to hydrocephalus is treated with the ventricular cerebrospinal fluid diversion. Prophylactic anticonvulsants are not routinely used for ICH. When seizures are not present at onset, patients are generally at low risk of developing seizure, but hemorrhage into cortex, regardless of site of origin, predisposes to seizures. Subarachnoid and intraventricular extension of bleeding does not increase the risk of seizure. Seizure have occasionally been reported with the hemorrhage of caudate, but not with the putaminal or thalamic event. Although the incidence of chronic epilepsy from ICH is low, any seizure usually begins within the first 2 years after the event. Prophylaxis against peripheral venous thrombosis should be accomplished initially with the pneumatic boots. Chemical prophylaxis may be started 48 to 72 hours after cessation of bleeding for patients not at high risk of incipient deterioration requiring surgery. At present, surgery may be indicated for lobar ICH in which patient continues to deteriorate and for cerebellar ICH. Emergent ventriculostomy to relieve hydrocephalus should be considered when this condition develops acutely. Surgical intervention has not proven to be useful for improving outcome of other intracerebral hemorrhages. The prognosis of ICH is worse for the larger lesion. By location, the pontine ICH has highest mortality followed by cerebellar and then basal ganglia lesion. Lobar ICH carries the most favorable outlook for survival and functional recovery. Clinical scoring system can provide insight into mortality and disability risk, an important consideration for the clinicians and patient and their family. The ICH score estimates the risk of death by 30 days and is predicted on the patient age, predicted on the basis of patient's age, admission, Glasgow coma score, hemorrhage size, intraventricular extension, and infratentorial origin of the bleeding. So this is IC score. If the age is more than 80, then one score has been allotted. Then GCS at the time of the presentation. If 3 to 4, then 2 score. If 5 to 12, then 1 score. If 13 to 15, then 0 score. If ICH volume is 30 ml, then 1 score. If not, then 0 score. If intraventricular extension of the bleeding is present, then 1 score. If not, then 0. If infratemporal origin of the ICH is present, then 1 score. If not, then 0. Then the total score is used to predict the mortality. If 0 score may be 0% mortality, 1 score carries 13% of mortality, 2 score 26% mortality, 3 score 72% mortality, 4 score 97% mortality, and 5 to 6 scores carries 100% mortality risk. Thank you guys.